And we move through now to our next topic on Eye on Health. And when we talk about women, we talk about hormones, we maybe look at the changes in women's bodies, the menopause, and then the conversation opens up about hormone replacement therapy. And I know women that have had hormone replacement therapy and have absolutely embraced it, and it's worked really well for them. But there's also been concerns around HRT and the connection, in some cases maybe, to hiring the risk of certain cancers in women. So to talk about HRT and to share your story, please, on 4001 or your questions, let me welcome to the show Dr. Basmah Al Rowaily, who's the Canadian Board Certified Family Physician, American Board Certified when it's anti-aging and regenerative medicine, based at the American Academy of Cosmetic Surgery Hospital in Dubai Healthcare City. Good afternoon and welcome to the show, Doctor.
Good afternoon. Thank you for having me.
It's a pleasure, particularly on this topic. It's sometimes a discussion people feel awkward having because it's about women and their bodies and changes in their lives and what's happening to them. But actually, in the age that we live in, we shouldn't be afraid of having these conversations. And it's about, again, as always with health, being fully aware and understanding what our conditions might be and understanding what's available to us. So when we're looking at hormone replacement therapy, when and why might this be something a woman has?
Usually around the late 40s or even sometimes mid-40s, the woman goes through changes. We call it the perimenopause. The lady will start noticing lots of changes in her sleep pattern, in her mood, in her bodily functions, in the way she's storing fat, in her eating habits, and new symptoms that she hasn't experienced before, like incontinence, having to run to the toilet, not able to hold her urine, dryness in her skin. So once a lady starts noticing all of these changes, it's very important to address them and verbalize them. Don't think that this is just natural. Maybe when you open up to your physician, and that's the importance of having a family physician, the minute you start noticing changes and you mention them, then you know that there would be a solution. And again,
they are a natural symptom to what's happening to a woman's body.
They are natural, but they're not supposed to be, affecting the quality of life of a woman. Once it starts interfering with your sleep, for example, or in your day-to-day communications with your family or people at work, then you think that this is time to tell someone about them. And usually it's one of the hormones that starts to be depleted 6 to 8 years before menopause. It's the progesterone. And if you just replace that, if you're having irregular cycles or heavy cycles, along with the other symptoms we've mentioned, the woman would actually feel much better. It's a trend now that I'm seeing with a lot of the women in their late 40s, of course, professionals, and they have the pressure of being a mother at home and again performing at work. And when they go from doctor to doctor seeking explanation to these symptoms, they end up being put on antidepressants, and this has become a trend. And I'm part of my being here today is to educate ladies and to help them take part in their responsibility towards their health. A bit of reading, a bit of research, and going to the right experts to help them deal with those symptoms.
It's really important to highlight that, and for the women, for the individual, but also for their family members. They might not understand why their mother or their wife is behaving differently, or is perhaps seeming to be more emotional, or is not sleeping through the night, or seems more stressed, and they might not put the two together. Why would they, unless that conversation can be had, that dialogue can be had?
True. And this is where our role is as physician, is to educate the public. And you're doing it through the media and on so many of the magazines. People are now very aware, and they do take a role in the decision of whether they want to start the hormones, to go natural ways, or supplements, or just a healthy lifestyle. All of these things are together. We always treat the patient as a whole. We do not just put them on hormone. We talk we talk to them about, de-stressing, about the importance of a 7-hour to 8 hour of sleep, of hydration, of the healthy nutrients, all of these, and we call them the hormone symphony because it's a symphony, not just one item that we address. We address the whole lifestyle of a lady.
So have you been suffering from some of these symptoms? Maybe you're getting dry skin, you've got insomnia, maybe there's night sweats, or you're noticing abdominal fat that you can't shift, looking at your age. Questions on this. You could be going through menopause, or it could be perimenopausal. We need to understand what that means. We hear that term menopause and it's like, we don't want to talk about that, but actually there's a large journey that a woman will go on as they go through what we call the menopause. It isn't something that maybe is just a couple of years. So understand what's happening to the body and how the body is changing and how it might be affecting your relationships as well. So questions on that, or indeed your experience of hormone replacement therapy, if it's worked well for you or not, let us know on 4001. We're talking about hormone replacement therapy and understanding this better with regards to women that are going through menopause or looking at slowing down that aging process. And Dr. Basmah Al Rowaily joins me, Canadian board certified family physician, American board certified anti-aging and regenerative medicine, based at the American Academy of Cosmetic Surgery Hospital in Dubai Healthcare City. And when we're talking about HRT, there's been a lot of conflicting information out there. Just to share with you very quickly a few headlines coming out of the UK. So the Guardian newspaper, HRT could benefit 1 million women, says the National Health Service menopause guidance. Another is saying, benefits from HRT outweigh the risks after years of conflicting advice. Major studies stating that. But then other articles are saying, no, actually, new HRT advice is biased and misleading, according to an Oxford professor. And so we're going to look more at those stories in a moment. But doctor, just to understand the menopause better and understand when we use that term, what are we really saying and what is the journey a woman will go on?
Menopause refers usually to a woman not having a cycle or menstrual period for 12 months consecutively. Years of irregular cycles, along with some of the symptoms I've mentioned. More and more estrogen depletion will cause her the hot flushes, the night sweats, the irritability, the dryness of the vagina, more of the urogenital infections, the incontinence, the dry skin, the obesity around the midline. So this is what menopause is, and as now more and more research is pointing to, the reason for aging is actually the depletion in hormones all over the body, not only in the sex hormones, but other hormones as well. We know that estrogen has an important function on the brain. It improves the cognition of a woman. It improves her memory, protects her from Alzheimer's. We know that estrogen protects a woman from cardiovascular disease, and that's why we see the prevalence of cardiovascular disease is higher among men until the lady reaches age of menopause, where her risk is actually exactly the same as a male. We know colorectal cancer also is prevented by some of the estrogen availability in a body's woman. Osteoporosis is one of the key important reasons for fractures, and this until now there hasn't been a single therapy that is more protective to a woman's bone than hormone replacement therapy. So I'd like to also touch base on these studies that you have mentioned, because we've been treating women with HRT for such a long time until the study, the Women Health Initiative in 2002 surfaced, and the study was actually conducted on over 16,000 patients who were postmenopausal actually, and the results of that study were alarming. They saw that it increased the risk of heart attacks, strokes, breast cancer. So the study was actually halted because of those negative outcomes. after further investigations into the selection of patients, they found a reason why these outcomes have surfaced. And first, they started very late. Most of the women, the average age was 65. The other reason, it was oral estrogen, and now we're not recommending oral estrogens at all as a replacement. The third one, it was the type of the progesterone that was used. It was a progestin, not a progesterone, and you need to understand these are chemically different hormones. Progesterone is natural. It's now it's available in the form of micronized progesterone, which is very protective for the breast and for the heart and for the brain as well. While progestin has the exact opposite effect, and it is the one that was responsible for most of the thrombotic or the cardiovascular events and the CNS events. So just to elaborate on that. Now there is, after 12 years, there is recommendation from the Society of Obstetrics and Gynecology and from the NICE guidelines to start ladies very early. So the minute she starts menopause, it's recommended that we do start her on hormone replacement therapy, provided that she doesn't have an absolute contraindications for them. And it's advised to go with the transdermal pathway, so we give the estrogen in the form of a cream or a patch, and we use the micronized progesterone orally or transdermally, preferably orally, for more protection. So once we know that selection of patient is important, the selection of the hormone is very important and key to us having the benefit versus the side effects of these hormones. And now the duration has changed, so now they say we should use them at least for the first 5 years, because this is where she gets maximum benefit on her bones, on her brain, on her cardiovascular system. And they recommended that we actually lower the dose of the estrogen. So we used to give, for example, 0.6, now we give 0.3 milligram of the estrogen. So that's in summary, just for women to understand what happened and why the guidelines and the media have changed from completely against hormones to now advocating to use hormone replacement therapy.
We'll explore these stories in a bit more detail, but just to clarify, when you're talking about hormone replacement, what is it? When you talk about progesterone, when you talk about estrogen as a replacement, what is it that you are replacing those hormones with?
Mm-hmm. We actually, for example, you know that it's very common for women after the age of 40 to start having a hypoactive thyroid, right? And we do give synthetic thyroid. We do give it's a replacement. We're just putting back what she has lost.
And when you say synthetic, does that mean chemical?
Exactly.
What is that? Yeah.
It's a chemical. Now, for hormones, estrogen and progesterone, they are synthetic, of course. All medications are synthetic, but depending on the structure. We want the structure of the estrogen and the progesterone to be as close as the one that the body manufactures. And that's why micronized progesterone is exactly like what a woman makes. There are now two in the industry, there are bioidentical hormones, which are usually extracted from yam, and there's another source which is in the pharmaceutical industry. It's called prometrium. It's from peanut oil. The estrogens are they are usually equine estrogen, and that was used in the Women Health Initiative, and it's from the urine of a horse, basically. There are now more bioidentical or similar to our estrogen, and they again take it from vegetarian sources like yam and so on.
When we come back, we'll find out more in detail about the research and the developments and the changes in perceptions and understanding of hormone replacement therapy, and take your questions as well. Keep them coming in on 4001. Talking about HRT this afternoon with Dr. Basmah Al Rowaily, who's Canadian Board Certified Family Physician, American Board Certified Anti-Aging and Regenerative Medicine, based at the American Academy of Cosmetic Surgery Hospital in Dubai Healthcare City, and really trying to demystify when we're talking about women, hormones, menopause, understanding what that process is and what the body might need, or what is an option, the choices out there to women to help alleviate some of those symptoms of menopause when it comes to insomnia, when it comes to hot flushes, night sweats, when it comes to foggy thinking or recurrent headaches or increase in abdominal fat. They're just some of the symptoms of menopause, and it's your body changing, it's your hormones changing, and there is hormone replacement therapy as an option. Now, we've been touching on a little bit what was been out in the media about HRT. Coming out of the UK, this was October 2015, the benefits from HRT outweighed the risks after years of conflicting advice. So doctors have said women can finally take HRT with confidence after years of fear that it may cause serious side effects. At least 1 in 4 British women who avoid the drug do so because of concerns about consequences for their health, things like breast cancer. Years before, there had been research saying that there were connections to this, and Dr. Basmah has been highlighting and clarifying what that means and how the research has moved on and changed. New York University scientists found women who took HRT for up to 25 years were no more likely than other women to develop diabetes, heart disease, breast cancer, or a raft of other problems, even after a decade of follow-up checks. The menopause, which strikes women in their late 40s and early 50s, can cause depression, and I said some of those symptoms. It can also lead to bone disease and memory loss. HRT tackles the symptoms by providing estrogen as the body stops producing it. That's coming from one newspaper from the UK. Another one in November 2015 is saying the new HRT advice is biased and misleading. According to Oxford professor, health panel that were presenting this didn't want to know about the research linking it to breast cancer. The official health watchdog was accused of being irresponsible and biased when they were talking at the panel over the latest advice on HRT. Now, in landmark guidance being brought out towards the end of last year, NICE, it's called NICE, and that stands for... It stands for the National Institute for Healthcare and Excellence, and the guidelines that they brought out was suggesting that you don't have to be so concerned about the connections. Consulting and marketing authorization holders, amending the existing warning about the risk of ovarian cancer, and goes on to write and present the document on that. Now, the reason I'm presenting all of this to you is at the end of the day, you have to do your own research. You have to ask the questions when you're seeing your medical practitioner or you're exploring your options if you are struggling with menopause and those symptoms. There is information out there and you have to weigh it all up. So, Dr. Basmah, we can come back on some of those points, but again, just to clarify on menopause, when we're talking about menopause, it's something that could go on for many years for women, and what you've been saying is HRT is showing, and particularly having the right kind of progesterone as a hormone replacement is, and whether it's synthetic or not, that's what is really key to this. But the earlier you do it in the beginnings of your perimenopausal, the earlier you can do it, the better it is for the woman.
True. As I mentioned, the perimenopause, or the average age of menopause, is between 47 to 53 years old. And once you start having the symptoms and you go to your physicians, you can then have the levels of these hormones checked to see where you are exactly. And the treatment can be started. As I mentioned, the route of the administration of the hormones is of key importance. For estrogen, it has to be transdermal to prevent the risks of a cardiovascular disease, of stroke, of increased thromboembolic phenomena, and the progesterone has to be a micronized progesterone for breast protection and to give you the benefits on a physician wants to start you on hormone replacement therapy. There are key guidelines of having a normal breast ultrasound, and I'm not a fan of mammograms, so I usually would request an ultrasound for my ladies if I'm going to start hormone replacement therapy. It's important to have a baseline pelvic ultrasound to check at the uterus and the ovaries, and to have your pap test done. These are of key importance. You need to have normal liver function tests, so a liver enzyme is going to be done for you. And so this is all to prevent side effects and to prevent the risk of developing complications later on. So when you start with your physician and you do it in a safe manner, and you're going to be monitored. It's not like we're going to start you on hormone replacement therapy and you're going to be seen in years from now. No, you need to be monitored. So we'll see you again in 3 months. We'll check on your symptoms and we'll check on the metabolism of these hormones. There's something called estrogen metabolism profile, and we do a urine check to see how are you metabolizing this estrogen. Some ladies are going to metabolize it in the bad estrogen, which is very inflammatory and thrombogenic, and some other ladies are going to go for the good pathway. It's called 2-hydroxyestrogen. So again, this is part of how medicine is evolving and improving so we are one step ahead of what complications going to arise. So once we know how you're metabolizing your estrogen, then I can either change your dose or maybe give you some nutrients to put you on the correct pathway for you to metabolize your estrogen the right way.
As always, it goes without saying, but just to highlight, of course, living the healthiest life you can with regards to your diet, your nutrition, your water intake, your exercise. Exercising can really help alleviate some of those symptoms of menopause as well. So you need to get that in check also. Just a couple of points then. So why are you against mammograms? Why do you not advise mammograms?
There's a small study that shows for women under the age of 50, there's an increased chance of breast cancer with radiation from mammograms. So that's why in Canada, for example, they do not start mammograms until the age of 50. In the United States, they actually do it at the age of 40, but every 2 years. So to be on the safe side, for me, do no harm is key to my practice. So if I have an ultrasound and it will give me a result good enough for me. If there's any suspicion, then I might opt for a mammogram or even MRI with contrast, just to reduce the risk of radiation.
If you have cancer in your family, would you still go on to HRT?
This has been the debate now. The guidelines have changed, both the NICE and the Society of Obstetrics and Gynecology. The contraindications used to be that if you have family history of breast cancer, you're not supposed to take HRT. It has changed in 2012 for the Society of Obstetrics and Gynecology. Only if you have a self, like you yourself have gone through breast cancer, then you are a contraindication for starting hormone replacement therapy.
Let's go to the text messages. My mum took HRT after having a hysterectomy and then stopped taking them because of the cancer scares. Her mood really changed once she stopped taking them. But now that she's 72, would it be something worth considering again to improve her general well-being and state of mind?
Again, at this age, as we know, there are other medical concerns that the patient might have. So, yes, of course, she would benefit. The quality of life, yes, for sure, she would benefit from that. But we need to make sure that she has really a normal cardiovascular condition. So her cholesterol level should be assessed, her insulin, whether she's diabetic or not. We choose when we put someone at her age on estrogen replacement, we're going to use the weakest type of estrogen, which is not atherogenic, and probably we're going to use it in the form to protect the urinary genital organs. Maybe a bit of estrogen for her cognition, but it's not that advisable without doing a really basic, comprehensive basic exam and checkup for her.
Or not. I mean, if a woman doesn't have any assistance through menopause and through the rest of their life, what does that mean to that woman? What difference would it really make to them whether they want to look at having that assistance through hormone replacement or not, just going through and putting up with the symptoms?
It's a personal preference and a personal choice. Having had education about what are the benefits It's up to a person to say, yes, I want to have more of my memory conserved. I want to have more protection for my bones. I would like to have more protection for my blood vessels and protection for my heart. I don't want to have a urinary incontinence. I don't want to have a painful, for example, intimate sexual life. And so I want to be younger. That's her option, to go to the hormone pathway. If she says, well, other women have lived naturally and this is how I want to age, again, it's her choice. And as we know, midlife now is at 60, not at 40, like what it used to be. So that's a personal preference. We are there to provide the knowledge and to provide the risks and the benefit, and it's for the patient to make the choice. But we like them to make an informed decision.
And talking about hormone replacement therapy with Dr. Basmah Al Rowaily, who's Canadian board-certified family physician and American board-certified anti-aging and regenerative medicine based at the American Academy of Cosmetic Surgery Hospital in Dubai Healthcare City. And when we're talking about hormone replacement, or indeed getting even tested first off when you may be thinking you are going through menopause, you're perimenopausal, what tests can be done, doctor? And if one then looks at options and maybe decides to go down the HRT route, what then happens?
As I mentioned earlier, we usually have a panel of baseline investigations for, we have to check for the thyroid hormone, we have to check for the FSH, which is follicular stimulating hormone, that is from the brain, ordering your ovary to function, to see whether you are close to perimenopause or you're menopausal. And then we look at the estradiol level, and that's the most important and the most potent estrogen in the body. We look at the progesterone level, and then we do the preventive screening, like your ultrasound for breast, for pelvis, the pap test, and then we opt, we make the decision along with you. We can do the synthetic or the bioidentical hormones, and once we start, we like to see you 3 months later. There are certain tests now where you can check with the saliva. The saliva, the advocates for the salivary hormone is that it gives you more of the availability of the hormone in the body compared to the serum, but both are good. You can screen with either one of them. Once you start transdermal treatment, for example, the saliva would be a bit more accurate for the estrogen, or the urinary, as I mentioned before. We're going to check the urine, and in that we're going to see where you are. We're going to see the ratio of your estrogen to progesterone. Sometimes we worry about estrogen dominance, for example, and that will be obvious from the patient's symptoms, where she would be having more retention, more edema, very irritable, palpitations, insomnia, and so on. So according to the ratio that we see, we depend on how we're going to gear the hormones, whether to give less of the estrogen, and we usually give combination if it's a bioidentical hormone. So I give more of the weaker protective estrogen and only 20% of the estradiol, because we still make estrogen in our body. Our ovaries will maintain to do some, to manufacture some estrogen, and also the adrenal gland. We also look at the stress level of a woman. So if someone has a very high cortisol, that's going to be reflected on her metabolism and her ability to utilize that progesterone. So if someone is really under a lot of stress, and I see that her salivary cortisol is very high, I'm going to put her on things that will bring down her serum cortisol. And usually these are, we call them micronutrients or adrenal support. These are really natural herbs and calming herbs for her to utilize her hormones in a better way. Alcohol, for example, this is a key destructor to the way you're going to metabolize your estrogen. It's going to drive your estrogen metabolism, and the pathologic estrogen. You're going to make more of the harmful, more of the carcinogenic estrogen. Eating refined sugars, saturated fat, again, is going to make you manufacture more of the harmful estrogen. So all of these things will be addressed every single time you come for follow-up.
Is this something you can claim on insurance?
Yes, for sure. Any lady who has perimenopausal symptoms, or we call it dysfunctional uterine bleeding, once she presents to me with irregular cycles, with other symptoms of perimenopause, I can always request her blood investigations and ultrasound, and it will be covered by insurance. The bioidentical hormone replacements, sometimes, most of the times, are actually not, but you can claim them with some of the good insurance companies.
What's the difference then, just to clarify, bioidentical hormone or hormone replacement therapy?
They're both hormone replacement therapy. The bioidentical hormones are the ones that we mentioned earlier, that they are extracted from vegetarian sources. So it's going to be from the yam mainly, the peanut oil, and they're a bit more expensive, and we actually cater. We can play more with the bioidentical hormone because I can put the percentage if I want. As I mentioned, there is estriol, estradiol, and estrone. We never use estrone because that's the harmful estrogen. So always my bioidentical is going to be composed of estradiol and estriol, and depending on the lady's symptoms, I'm going to do the percentage and the mode of application.
Question here, my mum was on hormone replacement therapy and suffered severe migraines during the treatment. I read somewhere that this means she's got a higher risk of suffering a stroke. Is this true or false?
Absolutely true. We know that people with migraine, they have high risks of strokes in general, I think 10 to 15%. Now, maybe she was put on oral estrogen, and again, this is why the recommendation was not to use oral estrogens anymore for any lady. It makes the blood pressure goes up, and it makes the thromboembolic phenomena increase. So your risk of DVTs, your risk of pulmonary embolism, and your risk of strokes is going to go higher when you use oral estrogen.
And if you choose to go down the HRT route, how long do you take them for? Do you take them for the rest of your life? How does it work?
Again, if I want to go with the Society of Obstetrics and Gynecology and the NICE guidelines, they recommend 5 years. If I want to go with the American Academy of Anti-Aging and Regenerative Medicine, where I want a quality of life and I'm using bioidentical hormones, I can continue for life.
Thank you very much for your time today. I've been talking to Dr. Basmah Al Rowaily, who's based at the American Academy of Cosmetic Surgery Hospital at Dubai Healthcare City. Thank you very much for joining me today. It's an important conversation to have and to open that dialogue up for women and their families. For more details on the American Academy of Cosmetic Surgery Hospital, we've posted up the information on our blog post today, so check it out at dubai1038.com/Dubai Today. Dr. Basmah, thank you very much.
Thank you for having me, and it's Dr. Basmah. I know my name is difficult for you to pronounce, just for the audience to know how to pronounce it. Thank you so much.
Thank you so much, and thank you very much.